welcome everyone to the 5-part ECHO series using telementoring to optimize quality of care and quality of life for patients with metastatic kidney cancer. We lovingly refer to this ECHO series as Toqq-Rcc, and we encourage you to do the same. I'm going to stop my screen here for just a minute, sharing my screen for just a minute. My name is Katie Knight. I am a member of the research staff at the University of Kansas Cancer Center within the Medical Oncology Division. My work is centered around cancer survivorship, control, and prevention, and I've been very fortunate to work on this project with Dr. Elizabeth Wolfe-Birchfield and Dr. Jennifer Klemp. And speaking of Dr. Wolfe-Birchfield, for those of you who've not met her, she's an assistant professor and medical oncologist with the University of Kansas Medical Center. Her specialties include genitourinary oncology and hospice and palliative medicine. Dr. Klemp, who will be, I think, touching base for just a few minutes here early on the ECHO. She's got a number of things going on today, but she's also a professor with the University of Kansas Medical Center, and her clinical interests are all things cancer survivorship, cancer risk, and genetics. Her interests are also, her research interests are also surrounding those same topics, but they also include improving access to point of service care through telementoring, which is a lot of what we're doing here today. It's really great to be here with you today. Libby, would you like to say hello and introduce our guest speaker for today?
Yes, absolutely. So we are so lucky to have with us today my wonderful colleague, Dr. Hamilton, who is an oncopsychologist here at KU and is one of our institution's experts in need assessment and distress screening, about which she will educate us today. So we're so pleased to have her with us.
Thank you for having me. I'm excited to be here.
Thank you. We're glad to see you. All right, so we're going to move through. I'm going to continue to share my screen, and we're going to move through some slides here. All right, here's just a quick review of today's agenda. I know that Tracy diligently sends these out to you via email as well, but if you haven't already signed in, go ahead and do that in the chat box.
Katie, we just lost you. Unmute.
Thank you. Sorry about that. I don't know what happened. I apologize. Here's a quick review of our agenda. I'm going to go through the next few slides rather quickly. They're going to be some housekeeping slides. As you know, our goal is to always start and end on time. I will move through these slides a little quickly, but I want you to remember that all of these slides and the recording of today's session will be available on the Masonic Cancer Alliance's website under their telementoring page. Also, on some of the slides, you'll see a little red toolbox, and that is an indicator that there's a resource on that slide that will also be made available to you on the MCA website. Okay, so I'm going to pause my screen here for just a minute so that we can meet those of you who are in the room. I will just haphazardly call on you. So just let me know your name, maybe what organization you're affiliated with, and your role that you play in oncology. And if there's any other little tidbit you feel like you need to throw in there, go right ahead. Tracy, let's start with you.
Hi, everyone. I'm Tracy McCarty. I'm with the Masonic Cancer Alliance. We are the outreach network for the University of Kansas Cancer Center. And welcome to everyone who's joined us today. I look forward to working with you.
Thanks, Tracy. Allison?
Hi, everybody. I'm Allison Hyatt. I'm a nurse practitioner at Tammy Walker Cancer Center in Salina, Kansas, and just work in the clinic setting, and we're working on getting a survivorship program started here. So happy to join in today.
That's awesome. We're happy you're here. All right, we've met Jessica, our guest speaker for today, and there's Dr. Klemp. Hey, Jen, you want to say hi to everybody?
Hi, yes, thank you guys so much for joining. I'm lucky to be part of this great research team with Dr. Wolfe-Birchfield and Katie, and I'm actually concurrently in a survivorship conference, so I will be popping in and out, but glad to be here today. Thank you for joining.
Thanks, Jen. All right, Amy? Amy, are you there? Amy, if you want to introduce, you can unmute. There you go.
Hi, I'm Amy Beebe, and I'm a nurse practitioner at via Christie Radiation Oncology in Pittsburgh, Kansas.
Awesome. Thank you for joining us today. Hi, Trish. You want to introduce yourself?
Hi, Trish Long, Masonic Cancer Alliance, and I'm the Navigation Services Director.
We're glad you're here.
Thanks.
And Mary Ellen. Mary Ellen is an integral part of this project as well.
Hi, I'm really glad to be here. I'm Mary Ellen Potts. I'm faculty with the School of Nursing at KUMC, and I do research in cancer care and hope to move into survivorship. So thank you. Looking forward to learn a lot.
We'll just drag you along with us. How about that? All right, Andrew.
Yeah, I'm Andrew Eilif. I'm a medical oncologist in Columbia, Missouri.
Okay, great. Glad you're here.
Yep.
Tim Metcalf.
I'm the manager of the cancer registry at the University of Kansas.
Thanks for joining today, Tim. Appreciate it.
Thank you.
Hi, Annie. Would you like to introduce yourself?
Whoops. Hello, I'm Annie Rogers, and I'm an outpatient palliative care nurse at the Westwood Cancer Center.
Oh, wonderful. It's nice to meet you.
You too.
All right. Miss Kathy Huey. Miss Kathy Huey Antwine, that is. You want to introduce yourself? Maybe not. She's probably got her busyness going on there. All right. Who is R. Newton? All right, moving on. We'll go with E. Magana.
Oh, that's Rhonda Newton. Sorry, she did comment in the chat box. She's someone we're pleased to work with here at KU, nurse coordinator, clinical nurse coordinator, and in GU, and she just doesn't have access to a microphone. That may be the case with Kathy Davis as well.
It probably is. Thank you so much, you guys, for being here. Appreciate it. And what about, is it Magana or Majana? How do we say that name?
Hi, it's Elissa. My last name's actually Nola, so it's irrelevant.
It's either one of those. That's great.
Yes, I'm a nursing supervisor in Westwood Exam at KU.
Oh, awesome. Thank you. It's good to see you and meet you. I'm glad you're here. Meredith Cooper.
Oh, hi. Sorry. It clicked on my other my other video. Yep, I'm Meredith Cooper. I am work on our quality team at the KU Cancer Center.
Okay, wonderful. Good. We're glad you're here, Meredith. And then finally, Catherine Davis.
I'm guessing she doesn't have a mic either.
Okay, that's fine. That's fine.
She and Rhonda, I think, are probably working from the same location, so that's why I'm guessing that.
Understood. No worries. We still have people joining us. So for those of you who didn't get a chance to introduce yourself, we're so glad that you're here. And we know that more people will be joining as we get started. Okay, let me go back to our slides here. It is really nice to meet all of you, and we're so glad you took time out of your day today to join us. Okay, so I am going to go through a few housekeeping slides. This first one is our conflict of interest disclosure for your review. The next couple of slides are going to review and give you all the information you need for continuing education credits. And for those of you who are not seeking CEs, we do also offer certificates of attendance. The activity code that you're going to need in order to get those CEs is O2HIS. And the deadline to enter that code is Thursday, April 22nd by 5 p.m. You can do this one of 3 ways. I don't know if you can actually do all 3 ways, but I don't know if anybody's tried that. But you can do it at least one of 3 ways, including entering the activity code through that number, through eads.com, or just downloading the app. Because of course there's an app for that. This project is funded by a Pfizer independent grant for learning and change. And of course, this project would not be possible without the additional support from the University of Kansas Cancer Center and the Masonic Cancer Alliance. Just a reminder, we do record these sessions, and by participating, you are consenting to be recorded. probably not necessary because I'm pretty sure we're all experts at Zoom at this point. However, to enhance your experience, here are a few tips. Make sure you keep yourself muted when you're not speaking. Testing your audio coming in is always quite helpful. Please speak clearly when you do participate. Use the chat box if you don't feel like talking. We have people monitoring that. Tracy's monitoring that chat box for us so we don't miss your questions. And then of course, if you have a camera and if you would like to show us your beautiful face, we would love to see it. So we love to have those cameras on. All right, so during echo sessions, we often have poll questions to enhance our learning experience. The prompts for these poll questions will just pop up on your screen. You'll give us your answer. And my favorite part is that we get to see real-time results. When do we get to do that, right? So today's learning objective is here, and we really hope that you walk away with an additional understanding of how to identify the physical and psychosocial aspects or effects, sorry, of cancer and its treatment. And finally, we aim to protect patient privacy. So when we have these discussions, please refrain from using any patient identifiers or personal information. Okay, that wraps it up for me for now in our housekeeping slides, and I'm going to pass the torch on to Dr. Wolf Birchfield for the next part of our presentation.
Thank you for that intro. And again, I second Katie's warm welcome. So pleased that you could spend this Friday afternoon with us. And, you know, while the Toqq-Rcc series was developed and funded as part of something that is focused about kidney cancer, so much, I mean, almost everything that we will talk about will have relevance to most other malignancies today. You know, we all know that, oh my goodness, the, you know, psychosocial impacts, distress, financial effects, symptoms, and, you know, risks of treatment, and on and on and on have so much in common with other malignancies. And so I don't want you to feel like this is only applicable for renal cell carcinoma. It certainly is not. And so thanks for, again, thanks for joining. So we can go to the next slide. When evaluating patients, in addition to trying to get a sense of their state, the cancer stage, cancer identity, treatment options, it's just clear that every patient we meet is a true unique individual who has a different narrative, has different life experiences and different needs. And the truth is that when we're meeting people, sometimes it's a little bit hard to know how to support them best. A lot of times folks come in with, you know, hoping to learn more about their disease, but they may not have even had the opportunity to think through what their experience has been getting the diagnosis and where to go from here. And so it can be difficult. For example, in the case of these gentlemen, they had their own goals that we were able to elucidate, but they didn't come in with any particular needs that they had identified or that they were able to state. So it's hard to know, how do we envelop these people with support? How do we make a path forward in addition to creating the medical plan for their cancer? So, you know, we all know that patients are much more than a diagnosis on a screen. And so we want to provide comprehensive care whenever we can. And so after doing some of the medical steps that we need to do in order to help figure out a path forward, a medical path, it's so important for us to understand how to care for someone as an individual based on what their experiences are, what their needs are, and kind of where they have gaps in their support networks. So trying to figure out what their symptoms are, evaluate their prognostic awareness and kind of medical understanding of their circumstances. Those are such important tasks. And it can be really hard, especially in early visits. My gosh, it's so hard to know how to prioritize because we often have kind of a water flow or waterfall of things that we're coming into. And so it's hard to know how to choose what is the most urgent in addition to making a medical plan for them. We can go to the next slide. So, you know, distress is really important, and we're lucky to have an expert with us today, Dr. Hamilton, who has really led the charge at our institution in developing needs assessments and to help patients understand distress. And so I'm going to pass the torch over to her to talk some about kind of the experience of distress from her perspective and knowledge as an oncopsychologist, and then to give us more information about how to screen for this in a patient-centered way that also is realistic with the workflows that we all that we all have to acknowledge and we all work within. Thank you, Dr. Wolf Birchfield. I'm so glad to be here today and to talk to you a little bit about what we've been doing at the Cancer Center as far as the implementation of distress screening. And I think it's important to note also the needs assessment. It's what we call, because we really want to identify what some of these comprehensive needs are for our patients. Distress is an aspect of that. But as you were mentioning with these two cases, it's a lot more than just a number. So being able to identify what those unmet needs are so that we can provide support for our patients. I also briefly want to give a little bit of kudos to Meredith Cooper, who's on the call today, because she's our quality person and she and I work very closely together in trying to get this implemented throughout our health system. So I'm so glad she happens to be here today and for all of her effort and support in getting this patients screened appropriately as well. So as far as distress and cancer care goes, we know that on average, 20 to 40% roughly of cancer patients are going to experience what we refer to as clinically significant levels of distress. And on an analog scale of 0 to 10, what is considered clinically significant is actually just a 4 or higher, which is really low. And I think it's something that we all need to kind of like conceptualize in our brain, as if somebody circles a 4 on a 0 to 10 scale, that's meaningful. That's where intervention actually needs to be occurring. And so keeping that and bearing that in mind, that 4 or higher is actually what means that it's clinically significant and interventions are appropriate. Where they're appropriate, I think, is the workflow and the question of what Dr. Wolf Birchfield was kind of referring to is like, again, that's just a number, but what's causing this distress? Where is it coming from? How can we help this patient in managing those symptoms? And that's where these other pieces pop into play. So distress is actually defined by the Commission on Cancer as unpleasant emotional experience of psychological, social, and or spiritual nature that may interfere with the ability to cope effectively. And I think it's lovely that the COC has defined it really comprehensively, of acknowledging that it's not just the biological aspect or the physical aspect. It also can be the psychological, the social, the spiritual aspect of a patient's life that's really important to kind of evaluate and figure out where we can support them again. Some of this distress can be pretty specific to cancers. I will tell you that bone marrow transplant patients typically have on the higher end of clinically significant distress. I know this is about renal cell carcinoma, but just as an important side note, those individuals going through renal cell carcinoma and then actually head and neck cancers are the two highest groups of clinically meaningful levels of distress. Renal cell carcinoma patients, though, obviously do experience distress as well, and they fall in that 20 to 40% range. If we want to go to the next slide, we can. Thanks. So distress is actually assessed now as part of a mandate for the COC and accreditation. So the American College of Surgeons started January 1st of 2015 that we have to or required to for accreditation to screen for distress at a minimum of one time point, pivotal time point in a patient's care. This has been kind of tricky for us because we need to make sure that we are hitting everybody that is coming through our cancer center, and not everybody's going to get chemotherapy. Not everybody's going to have surgery. Not everybody's going to have radiation or immunotherapy. And so we've been working really hard to try to figure out when and where we should be assessing distress. How we should be doing it or implementing it is also something that becomes important. So for example, communicating verbally with a patient, they're going to be less likely to report their true distress. They're going to minimize their distress. So we want to make sure that if we can do this with pen and paper, that we're evaluating distress with pen and paper. The other thing that I think kind of comes into play with workflow issues is that this sometimes feels like another task because it's a mandate. And so it's just another checkbox that we have to do as providers or clinicians or nurses or support staff. And, you know, I myself, every once in a while found that I'm like, everybody's just scoring 0. Why are we doing this? Well, if we have the conversation with the patient afterwards, that's meaningful to them, and it can help with patient satisfaction and patient experiences. But more importantly, it can actually reduce the amount of time that we spend in the room with patients because it gives us direction. It tells us what conversations we want to have with our patients and where they should be occurring. And so we don't go in blind as providers. We can say, oh, you're having trouble with practical concerns. You need help with rides. Let me get you a social worker here so that we can help with transportation needs. So even though it's a survey, making sure that we look at that survey, it can actually reduce our time with patients and provide us with direction, as well as allow the patient to feel supported and meet those needs. So while it is an accreditation factor, it is something that we can use to help identify patients' needs. And we identify patients' levels of distress. That's that grayed out column on the far left. In the middle section, we have what we refer to as our unmet needs. And that's that part that can help guide the conversation with patients. We look at practical concerns, emotional concerns, nutritional concerns. We also have spiritual concerns and physical concerns. And that goes along with what that comprehensive definition was. I will say that we have recently started to try to look at, instead of spiritual concerns, we've looked more at some of the substance abuse concerns, because that's another really important component of cancer care and providing unmet needs. Is so we actually started to use some substance abuse questions in this section as well. Our third step, which I find extremely unique when we look at other cancer centers, is the ability for a patient to self-select supportive services. So they can have the option to see a social worker, a psychologist, a dietitian, chaplain, wellness provider. We are lucky to have a rehab oncologist as well as palliative care services, and patients can ask to see those services as well, which makes me very happy, because we really want the patients to be aware that they have the option and opportunity to get all of these different comprehensive services, because we're a really great cancer center. So we're going to take a quick poll here. So which of the following needs seem the most frequent or most urgent among new patients in your practice or your community? My thing came up for me to vote, but I can't vote as a panelist. It's kind of funny.
I know.
Cheating.
Tracy, does it look like everybody's pretty much contributed there? Got 10 out of 14. Poll is now closed.
Okay.
So these are our results. Like practical wins the day.
Yeah, this is very interesting. So I would have, if I was cheating, I was going to put practical. So I would have fallen in that group with people too. Oh, can I?
And it looks like there is a question, Dr. Hamilton, from Dr. Potts, saying, does the person giving the survey to the patients explain what the support person does, meaning a social worker versus a psychiatrist versus a psychologist, et cetera?
So that's a really great question. And only if the patient is asking. One of the things that we have done in the past is we have a handout or a flyer that just briefly goes over what all the supportive services are and what they do. And that is hopefully being given to the patient when they're also given the form, so that if they wanted to refer to that, they could. But the goal for us, and as you look at this next slide with the workflow, is actually for patients to always be able to have the discussion with the provider afterwards. Our workflow is actually created so that it's driven by that conversation, not necessarily by the results of the distress thermometer. So as far as workflow goes, I'm going to break this out very quickly. So in our chemotherapy patients, we usually do distress screening at what we refer to as second touch or toxicity check or education appointment, depending on the location at our cancer centers. So it's not the first appointment. And we do that because a lot of times at that first appointment, there's a lot of distress, elevated feelings and emotions, because it may be the first time that they're being told that they have cancer. It also could just be the first time that they have so many unknowns and so many questions that when they go into that appointment, their anxiety is really high. And we wanted to try to get a better objective measure of what patients' distress levels are, so that we're treating people who actually are in need of different services. At BMT times, it's completed at the initial consult. At radiation, it's done the first and third weeks of the month.
And then at surgery, surgery is post-op, and inpatient is supposed to be within 48 hours of admittance. So that's kind of where we're doing our distress screening right now. At our cancer center, anybody who scores a 6 or higher on the needs assessment on that first step, that would be an appropriate time to refer to a supportive service of some kind, or the physician to address whatever those physical needs might be. On step 2, anytime there is 2 or more needs that are endorsed, that's definitely a time to put a referral in. However, if you have a patient that endorses one practical concern related to transportation or needing a DPOA or whatever, that does not prohibit you from referring to social work. That's one of the questions I sometimes get. No, that absolutely does not mean you can, if there's just one that's identified, you absolutely can always refer. It does not have to be 2 or more. And then on step 3, obviously, if somebody requests a service, we want to make sure that we offer them that service. If somebody is having significant emotional distress, but they do not want to see a psychologist, it is not beneficial for them to be referred to psychology. And I point that one out specifically because, yes, patients are going to endorse emotional concerns. This is where that conversation becomes important with the team and the provider, with the patient, because we want to make sure that just because they are experiencing emotional distress, we need to identify what they want to help manage it. And that does not always mean a supportive service. That may just be, I just want to have a conversation with my provider, and that may be it. But figuring out what it is that they're wanting and allowing them the opportunity to have those resources, really what's important. And so that is kind of how that workflow goes. Does anybody have any questions? I think something popped up, but I haven't read the chat. I think this makes me think sometimes of kind of advanced care planning in the way that, having the form is good, but prompting the conversation is really where the gold is. Yes. Giving patients a forum, a safe forum to identify some needs. And I think sometimes it even just crystallizes it for them, so that then we can explore that and get them services if they're needed and wanted. But that's kind of how I think of it, is, not trying to bypass the clinical relationship. We're trying to enhance it.
Yes, exactly. And again, what research has shown is that it will really actually end up in the long term reducing the amount of time. So sometimes people think, oh, well, this is going to extend my visit. It doesn't extend the visit. It actually can help expedite the visit, which I think is an important thing to reinforce with teams as well. As far as our unmet needs go, when you look at the data that we have, this is kind of a breakdown of how many patients are endorsing specific types of unmet needs. So for example, practical concerns, which we would generally refer to social workers to help, you can see that 12.9% of people identified that they had at least one unmet need. 32 or 4.4% had 2, and 3 of them had 2.4% had 3 or more unmet needs, for a total of 19.7% of our patients identifying practical concerns or unmet needs. Emotional concerns is roughly around 30%. Dietary needs was 46.2%. So this is an area where we know that actually we see most of our patients seeing nutritionists because of the unmet needs that are going on there. And it can be quite complicated. And getting resources for food is not always easy. I don't know if you guys have had that experience, but a lot of times our dietitians and our social workers will have to collaborate to get food services available to our patients. Physical concerns was just barely higher than dietary concerns at 47.5%. And then spiritual concerns is actually at the highest, 48.4%. However, those unmet needs, actually, it's inverse questions. So these are things that they find important, but they don't necessarily need. So I think it's important to kind of identify that it's kind of like a false positive. As far as referrals go, this is where things are kind of interesting in my opinion. But so we have psychology services. 31.8% of our patients were referred to psychology or actually saw psychologists. That is an almost exact match of the number of patients who were having emotional unmet needs, which is great. That's actually what we want to see. For practical concerns, we have 50.4, and only 19.7 or 20% roughly of our patients were identifying practical concerns. So there's a real higher number of patients being able to see social work.
even if they're not identifying possible needs that they may need. Financial counselors, 72.3% of our patients saw financial counselors. This is another one of those mandates that patients before they start chemotherapy are going to need to meet with a financial counselor. So I think that that's why you have that elevated number. And then for dietitians, 39.4%, which is about 7 or 8% lower than what was reported as far as unmet needs goes. And I also think that this is, if you think about where we're doing our needs assessment, we aren't looking at them long-term. We're not reassessing patients' dietary needs. And I think that that's a gap and an area that we could improve upon, because I think a lot of times patients need dietitians up front, but then as they move into survivorship, it becomes a whole nother ballgame.
Absolutely. They really do change quite a lot. The nutritional needs. Yeah.
So I'm going to stop the screen or stop sharing for just a second, just to give people an opportunity to ask Dr. Hamilton any questions. Not all at once. I know Mary Ellen put a question in the chat box, and it was a good question. I know that Libby responded to it, but I just wanted to say and ask, give Dr. Hamilton the opportunity to chime in. She asked if how do you explain to patients kind of what a social worker, a lot of people don't understand social work and the roles that sometimes they can play, particularly in oncology. And so Mary Ellen was kind of curious about how that is explained to patients. And obviously there's plenty of people being referred and utilizing the service. So
yeah, so as far as our supportive services goes, we do have a handout that kind of briefly describes what each of the services are. I think team by team at our cancer center, it kind of depends on what the team makeup is and how they want to utilize services. I know that for a long time, and I think this still holds true in most instances, that we try to get most of our head and neck cancer patients very early on set up with a nutritionist or a dietitian, as well as a social worker, because of those unique circumstances with their cancer care. With renal cell carcinoma, I feel like social workers and dietitians are they're still very important components of the game. Breast cancer social workers are almost always involved from the very, very beginning of cancer treatment as well. But our social workers' jobs are really related to case management a lot of the time. They are awesome people. They get individuals resources, they get DPOA set up, they get transportation, lodging. If there are foundational supports, they're aware of them, and they get grants and funding for prescriptions to trips to whatever it might be, help getting house cleaned, whatever it is, and getting family involved and supporting them along the way, getting referrals for PT, or if they need physical help or other items, they're also usually really readily available in the clinic for them.
Awesome.
That has changed a little bit with COVID, because they only have one person at the cancer center at a time, but there's a lot of phone calls and getting patients to different resources that way.
Awesome. Thank you. Thanks for that.
And Mary Ellen also asked about whether all of the cancer clinics, I don't know if she means at KU or more broadly, but so the folks who are seen at any cancer center, KU cancer center location, have access to the same supportive care resources. But we're very lucky because, being part of an institution that's on the bigger side means that we have a lot of resources at our disposal. And I know that my, colleagues and co-fellows and friends who are in different practice settings don't always have the same on-site access that we are lucky to have, with psychology and onco rehab and palliative care and on and on. So there's a wide spectrum, I think, across oncology in general. Well, thank you so much, Dr. Hamilton. So, to bring it back to the case, because, again, that's always how my brain works. And to think like, okay, well, how do I center it? So, the reason that I brought up these cases, and we're kind of coming back to them now, is to say that, both of these gentlemen are around the same age. They're the same identified gender. They both have intermediate risk metastatic clear cell renal cell carcinoma. It's even the same grade. But when we really look at their needs kind of through something like a needs assessment, we really see that they are very different because they just have different expectations, different psychosocial support or gaps. So for Mr. A, when we really look into his needs further, it was determined that he does have some, he would like some support, but more peer support. He would kind of like to, he would love to meet with a wellness coordinator type person that we have, and also do whatever he can to educate himself about his disease and find peers who have a similar disease or disease state that he does. And Mr. B had a lot of practical and financial concerns. So he, because of his inability to work due to his symptoms, he had a lot of financial insecurity, and so he needed help kind of with disability and things like that. He had physical concerns with pain. He had nutritional issues and needed to meet with a dietitian, and he self-identified as wanting to meet with a social worker. So I think this is one of those things that if you just look at the case, the vignette by itself about, these are two folks that have a very similar disease on paper, have very different needs, and we as a team need to really flex and do different things for them. Well, to pivot a little bit, so, in thinking about kidney cancer, since that was the theme of the series, there is one aspect of this topic today that really is kind of a couple aspects that are unique to kidney cancer specifically. But, kidney cancer, we have so many wonderful treatments now, a lot of which have become approved in the past few months even. But, we've had this wealth of data that helps us to risk stratify patients for a while. There are two of them, the MSKCC and then the IMDC risk calculators. And while, and that has evolved as a really important part of assessment for folks who have kidney cancer specifically. And the reason is that treatments are actually approved based on their risk categorization. So I brought this up just to say that this is kind of another medical aspect of the assessment. Initial patient assessment is trying to calculate that risk categorization. And, we only do it one time, which is essentially around the time that they need to be starting systemic treatment. We don't need to kind of recalculate that, even though Dr. Hamilton pointed out that we should be redoing assessments for some of these domains repeatedly, particularly nutrition. So in any case, I just wanted to bring that to light and remind everybody about that. We can go to the next slide. And, once kind of you've made a comprehensive patient assessment, or you're in the process of doing it, the whole point is to kind of put things back together and figure out how does this all contribute to a medical and support plan for this person. So, when it comes to having a good sense of their, psychosocial and needs and support and symptoms is essential. Once we know their IMDC or their MSKCC risk stratification, that's another factor that we'll incorporate. The decision-making about cytoreductive nephrectomy in this population is really complicated, and we're going to talk more about that in a subsequent session, because it was for a long time considered a standard to remove that kidney that had the tumor in it. However, some recent data has suggested that some folks may either need to bypass that or may be able to bypass that. So we're going to talk about that in the following session. And then I think another factor to consider is, is this person, could we offer in good conscience metastasis-directed therapy to this person versus needing systemic therapy? If folks really have truly oligometastatic disease that's either synchronous or metachronous, low volume of metastases, particularly if they are lung metastases, because those seem to have the, kind of best or the least bad, I guess you could say, prognostic implications. But, that's another factor that I always try to run through for myself, is trying to figure out, should we be removing this person's kidney? Should we be thinking about focusing on surgical or radiation-based management rather than systemic therapy for now? So one pearl is I would try and avoid metastasis-directed therapy as a primary treatment approach for folks who have liver or bone metastases, because it seems that those are worse prognostic signs. And finally, we can always start with systemic therapy and then do consolidative treatment to these sites. But, this table I've made to reflect kind of the current first-line treatment landscape for kidney cancer, which is, this has been revolutionized over the past 2.5 years. What a blessing, and also a challenge for all of us who are making treatment decisions. And so I put this up here on the screen just to show that even though we're all taught that we shouldn't try to determine what treatment is best by comparing different individual trials, instead, we would ideally want a trial that compares all the different interventions. We don't really have a choice. We have to do that now. And there are a lot of different factors. As some things I'll point out to you are that some of these treatments have a higher overall response rate than others. So for example, on the far right, the lenvatinib and pembrolizumab combination that was just presented, 6 weeks ago or so, or maybe 2 months ago, has the highest overall response rate that we know. And that's really important. But also, the one contrast I would make to that is just to see that the hazard ratio for death here is very similar between these. And so more is the idea that more is more doesn't necessarily hold true. I think we don't know. But, and I wanted to bring this up especially because while I don't think everybody needs the treatment with the highest overall response rate, depending on their medical circumstances and their goals, I honestly think it's not always the answer for some folks, for a lot of folks. But if they're highly symptomatic, then I really do think that's when overall response rate is really key. Really, really key, because their symptoms are going to be due to their cancer. So the faster we can get their cancer controlled and the deeper control we can get them, the better their symptoms will be and their quality of life will be. So that's one reason to put it up there. Thanks, Katie. You can go on. So, and I love this phrase, an embarrassment of riches, because I think it's just such I'm humbled to work in a field where we have multiple treatment options that are all so good. And I wish every patient's disease had that. But what I would say is some questions I think that remain now about choosing a treatment for folks is, how much should we factor in the overall response rate or the complete response rate? Does that matter? I'm not sure. I don't think any of us are sure that it does, because since it looks like the overall survival appears similar, then the question is, does pushing them harder really, is that meaningful overall? And on an individual level, is it meaningful for a given patient? We also can't compare the toxicity across all of the trials. And for example, the lenvatinib and pembrolizumab trial was recently presented, but they didn't present quality of life data. So we really don't understand that patient experience well, and it's hard. That's an important factor in making decisions. And so I think there are a lot of questions about whether more toxic treatment is really worth it. And so I think we'll hear more to come on that, but also I think it's very appropriate to personalize your treatment offerings to patients based on their circumstances. So, and especially because, and I recognize that my role as a GU oncologist is very different from some of my dearest friends and colleagues in oncology, because I am only treating GU malignancies. I have in awe of so many folks I know who just are taking on the world every day in clinic. They're treating myeloma and breast cancer and glioblastoma and kidney cancer and on and on. And that is really worthy of praise, because that is the biggest challenge. And especially when facing something like that, I do think it's very tempting to just kind of say, okay, for kidney cancer now, all I'm going to offer to folks is lenvatinib and pembrolizumab, because that has the highest overall response rate and highest complete response rate. And that makes the most sense. And I think that's not medically or ethically wrong. And I think by knowing even some of that data, that makes you a good clinician. And so that's wonderful. And I also think, though, it's ideal if possible to kind of factor in, knowing that we have the latitude to use patients' frailty and goals and medical comorbidities and social support to choose a little bit more of a personalized treatment for them. That's not, kind of cherry picking. That's not negative. That's patient-centered care. And so while not all of us have to be masters of every regimen, that is far from necessary, since we have to have a wealth of treatment options. I think when possible, to have a couple under your belt, one of which you have more, a couple that you have more experience with and know may be more or less tolerable in the folks who you treat, and some that may be more intense but may have a higher complete response rate, for example, that I think is ideal, because then you can personalize it a little bit. Next slide, please. So, okay, so one poll question is, so even when we know what the best treatment regimen is for a patient, the cost of treatment, especially for oral medicines, my gosh, it can really create barriers. So, one question I have is, because this factors in as financial distress, have you had circumstances where any of you who are clinicians and recommending treatments for any cancer, that patients haven't been able to get the treatment that you actually think is best, or your group thinks is best for them, because they can't afford it? And if you have experienced that and have great resources to advise all of us and mentor all of us, then please share in the chat box, because we want to learn from each other.
I think it's fair to say the majority here already is agreeing with.
Yes. Isn't that hard? That's so heart-wrenching to see. That's just devastating to all of us who really, I think, are all just do-gooders. We want to help people live their best. So it's heartbreaking to see. I know that we here at KU have some folks who are able to work in our specialty pharmacy who can help match patients with copay assistance programs and things like that. But if anyone has other experiences or any tools that, with community support groups or other resources, then please, if those pop up, share them in the chat box so we can all take advantage of that. So, when kind of pulling it back to the case of these gentlemen, and thinking about them, they both, as I said, have this IMDC intermediate risk disease. One of the gentlemen has very few symptoms, and one is very symptomatic, is not able to work because of it. Mr. A is really motivated by, he's sort of one of the folks who would say, well, I mean, I don't want to die. I want to treat my cancer, but if I can choose something that's the least burdensome for my symptoms, especially specific activities he wants to do, then all the better. Versus Mr. B, who is very motivated by longevity and has, at least for metastatic kidney cancer, kind of aggressive longevity goals. And so he's willing to prioritize that. So I think that those things we would also factor in. And next slide, please. And so, when I am thinking through these two gentlemen, Mr. A isn't the person who has to get a response or he's going to lose his window to treatment. And also palmar plantar erythrodysesthesia or hand-foot syndrome would be a really problematic symptom for him because friction really increases the risk of that. And so putting him on a TKI with a really high chance of that, like lenvatinib or cabozantinib, right off the bat is kind of in opposition with some of his goals. Versus Mr. B, who really, he needs relief immediately. And if he doesn't get better clinically, then he may not be able to do any more treatment after a relatively short time. So, that's kind of some other things that come up for me. Next slide, please. And so for Mr. A, my recommendation was actually the nivolumab plus ipilimumab. He's highly educated and he has a lot of insight into his own body. And it felt pretty clear to me that he'd be able to communicate with me anything that's changing. And because one of his goals was to avoid side effects that I personally consider to be very tightly linked to TKIs, one of my goals was to help him avoid that. For Mr. B, absolutely what he really needs is he needs a response. And so we need to go with the treatment that has the highest chance of that so that he can get back to living. We can always mitigate toxicity when we need to. But, I think that something like lenvatinib and pembrolizumab or cabozantinib and nivolumab would be the best choices for him based on their overall response rates. So that's kind of my framework. So on paper, they sure look similar. Two men are similar ages, same risk stratification, same diagnosis, same disease, same stage, but they really need individualized treatments because they have different goals, different needs, and in order for us to really support them as unique individuals in this setting, it felt like they needed different treatments. So that's I'll leave you with clinically there. Any other thoughts or experiences, struggles that anybody has in, helping patients get acquainted with their practice, helping folks, with initial assessments or financial toxicity or anything that comes up?
Dr. Wolf-Birchfield, I appreciate you sharing. I mean, over the years of oncology nursing, I've been in it 35 plus years now. And back then it was, oh, breast cancer, this is what you get. This is what you get. And I love now, and I have to, side note of being a palliative care nurse that has changed my eyesight. But that, yes, Mr. A has renal cell carcinoma. I like to say to them, I don't want that cancer in my mind to identify my patient. I like to take that cancer off, put it aside, let Dr. Wolf-Birchfield deal with that. And I want to look at that patient as Mr. A and his individual needs of psychosocial, spiritual, financial, social, however, all those things that we look at and really hone in on what's best for him. So I'm so thankful that providers are looking at that as well when they're deciding these treatment plans. And looking at quality of life and what are the goals of the patient, and listening to them, that's the key. And I love that about our system. I love that about I get the honor of working alongside Dr. Wolf Birchfield at times. And it's just so cool, folks, to see where we've come with this medicine. It really excites me and gives a lot of hope for our patients. So thank you for sharing
Thanks,
today.
Annie.
Mary Ellen did have a question about social services, whether or not, I don't know if I can find it exactly, but basically she was asking, you know, do the same types of services, support services, are they available at most cancer clinics? And I think the short answer is it just depends. It depends on the resources. It depends on where that cancer center is. And, you know, there's just a lot of ifs there. But of course, KU is well equipped with plenty of resources, but that is definitely not the case for every cancer center. Okay, any other questions for Dr. Hamilton or Dr. Wolf Birchfield? All right, well, let's wrap this up. I do have one more thing to talk with you about. First of all, thank you, Dr. Wolf Birchfield, and thank you, Jessica, Dr. Hamilton. Appreciate you guys for taking time out of today to give us such great information. And we're looking forward to all the future sessions as well. One thing before we go, though, you know, we know oral oncolytics offer a host of benefits for patients and providers, but cancer programs really need to be well equipped to properly specifically manage and monitor those patients who are self-administering their treatments at home. So we would like to challenge you and your practice teams to conduct this simple workflow analysis. Doesn't have to be anything fancy. It could even just be you sitting, you know, for 5 minutes at your lunch hour, just kind of going through in your mind this process. Should you take the time to complete it, we do think it would be beneficial to you. You will also, if you could also send it to me, the completed worksheet, then A, you would get extra brownie points because those are amazing. And then B, also you would really greatly enhance this Project Echo with the data that we can collect. So we are going to encourage you to do that. A little bit of homework for you, but we're not going to call it homework. Please join us for the next session, which will be Friday, May 14th at noon. We will have guest speaker, Dr. Eugene Lee, and the discussion will be centered around shared decision-making for medical and surgical renal cell cancer treatment. So we certainly hope you join us for that. And then finally, don't forget about those CEs. Your identification code is O2HIS. Again, due Thursday, April 22nd at 5. And most importantly, remember all of this information is available to you or will be made available to you on the Masonic Cancer Alliance website under that telementoring page. So we have a couple of minutes left. If there's any other comments, questions, then you guys are welcome to chime in. I'm going to go with that's a big no. Maybe next time we'll have more to discuss and more questions, but we know you guys have lots of options to spend your lunch hour, and we appreciate you spending it with us. So everyone have a great
Thank you all so much.
Yeah, thank you.
Yeah, and join us for shared decision making. Always a juicy topic.
Absolutely.
Yeah.
Thank you, everyone.
Have a good Friday.
Thanks, everybody.